So moving to your histopathology. I told histopathology, we see lot of your cell types here because your intercalated and your excretory duct will give rise to a variety or differentiate into variety of cell types. So if you see the variety of cell types here, predominant cell types will be your mucus producing cells, the squamous or the epidermoid cells, and the intermediate cells. The other cells which are seen in minor number will be your clear cells, your myoepithelial cells, the cuboidal or the columnar type of your cell. So we will see each cells in detail now. So this mucus cells, if you take your mucus cells, it is the largest cell which you see in a mucoepidermoid carcinoma. So it can be different shapes can be appreciated. It can be either cuboidal shape, columnar in shape, oval in shape, round in shape, or polygonal in shape. So it is going to be a very large cell, or different shapes can be appreciated, and it has a prominent nucleus which will be pushed to the periphery. The characteristic finding here will be the cytoplasm here. If you see the cytoplasm of this mucus cell, it will be a foamy cytoplasm. Okay, pale eosinophilic foamy cytoplasm. What do you mean by this foamy cytoplasm? You have seen the foam, the soap foam, right? If you dip it in pink color, what will be there? The bubbles of the foam will take up the pink color. The other areas will appear empty. The same way, the soap bubble appearance or the foamy appearance can be appreciated here with a pale eosinophilic borders. So foamy cytoplasm, pale eosinophilic, abundant foamy cytoplasm. And if you see these mucus cells in the tumor area, they will be seen lining the cystic spaces. If you see the mucoepidermoid carcinoma, it consists of cystic spaces. The low and the intermediate grade will consist of cystic spaces. So these cells can be seen lining that is the epithelial lining of your cystic spaces, or they can be seen as separate islands or clusters of cells in the tumor area. So they can be seen lining the cystic spaces or as clusters of mucus cells in the tumor surrounding connective tissue. And if you take this mucus cells, it will be positive for your mucicarmin stain. Because it contains a mucin there, it will be positive for your mucicarmin stain and your periodic acid shift stain or the PAS stain. So the mucus cells will be positive for your mucicarmin and your PAS stain because it contains lot of your mucin within the cytoplasm. The next cell will be your epidermoid cells. The epidermoid cells I've already told, it nothing but it resembles like a squamous type of cell. So it has a squamoid features. What are the squamoid features? It has a polygonal shape, okay, and prominent intercellular bridges, prominent cytoplasm, or the cell outline can be seen. Okay, these are the prominent features of your epidermoid cells. Along with that, these cells can show individual cell keratinization. Going back to your squamous cell carcinoma or the dysplastic findings, the individual cells can undergo individual cell keratinization or sometimes keratin pearl formation. Same way here also, these epidermoid cells or the squamous type of cells can undergo individual cell keratinization or your keratin pearl formation. So the mucus, along with the mucus cells, you will be able to appreciate your epidermoid cells, which can form your individual cell keratinization and your keratin pearl formation in the tumor area. So if you take the epidermoid cells, it is polygonal in shape, prominent intercellular bridges, the cellular outline is very prominent, then the cytoplasm is very prominent here, and your nucleus is also dark hypochromatic with a prominent nucleoli can be appreciated, and these cells can undergo individual cell keratinization or keratin pearl formation can be seen. The next cell type is your intermediate cell type. The intermediate, the one between your mucus and your epidermoid cells. That's why it's called as an intermediate cell. This intermediate cell, I've told already, it arises from your myoepithelial cell. It's also called as your maternal cell. Okay, this is also called as your maternal cell because this cell can also give rise to your mucus or the epidermoid cells. So
intermediate cell arises or it's from the differentiated from your myoepithelial cells. So intermediate cell, what they are saying is it's a highly differentiated myoepithelial cell, and it's also called as a maternal cell because again this can differentiate and give rise to your mucus or the epidermoid cells. And if you see the morphology, the appearance of the intermediate cell, it has a basaloid appearance.
Baseloid meaning it resembles like a basal cell. How does a basal cell be? It will be small cuboidal cells with a large hypochromatic nuclei with minimal cytoplasm. Same way here also, the intermediate cells will have a basaloid appearance with a large hypochromatic nuclei, and these nucleus can show the mitotic activities also. Along with it, the nucleus cytoplasm you see is very minimal. It resembles like a basal cell or stem cell. For that's why it's called as your maternal cell, because it can give rise to your mucus or the epidermoid cells. So if you take the intermediate cell, the basaloid cell, that is basal cell type, either cuboidal or low cuboidal with a large hypochromatic nucleus with a minimal cytoplasm, and it's also called as the maternal cell because it can give rise to or differentiate into a mucus or a epidermoid cell. The next cell is your clear cell. So what is this clear cell? The name itself indicates it's clear. It is empty. So it will be a large polygonal cell with a clear vacuolated cytoplasm. Okay, clear vacuolated cytoplasm with a prominent nucleus there. That is your clear cell. So these clear cells can also be appreciated in case of your mucoepidermoid carcinoma, especially in your intermediate and your high-grade tumors. So what are these clear cells? They are glycogen-rich clear cells. These are large polygonal cells with a clear vacuolated cytoplasm with a prominent nucleus, and the cell outline of the cell borders are very distinct or very clearly seen. So if you see all the cell types we saw about the mucus producing cell, the squamous or the epidermoid cells, and the intermediate cells and the clear cells. You know the myoepithelial cells. These are spindle shaped cells, right? With lot of processes there. So these myoepithelial cells can be seen, and some amount of your cuboidal or columnar cells can also be appreciated. So these are the cell types or the cell variety what you see in your mucoepidermoid carcinoma. Based on this cell type and the pattern of arrangement of the tumor, it can be graded as either low grade, intermediate grade, or a high grade. So moving into the grading of your mucoepidermoid carcinoma, it will depend upon the amount of your cyst formation. How much of cystic spaces are there within the tumor? Second, the amount of your mucus cells. The amount of mucus cells which is going to be present there. And the degree of cytological atypia, whether the atypia is there or not, or the amount of the atypia which is going to be present. So based on these three criteria, it has been graded as low grade, intermediate, and a high grade tumor. So it is based on your cyst formation, degree of cytological atypia, the amount of your mucus cells which is going to be there, or the proportion of the cell types, the amount of cell types which is going to be there. So starting with your low grade. If you take the low grade, the first thing is your cystic formation. It will have lot of cystic spaces. So lot of cystic spaces are going to be there, which will be lined by your cells. So the cells which are going to be lining these cystic spaces will be either your mucus cells, okay, the large foamy cytoplasm mucus cells, or the cuboidal cells or the columnar cells can be seen lining the cystic spaces. And these cystic spaces will contain your mucin pooling there within it. So it will contain mucin pooling with large cystic spaces, which will be lined by your mucus cells, cuboidal or columnar cells. The surrounding stroma, if you take the surrounding stroma, it will show clusters of your mucus cells again, and few amount of your intermediate and the epidermoid cells can be appreciated. So if you take the low grade tumor, it consists more of your mucus cells, more of your cystic component, less amount of your intermediate and your epidermoid cells. And if you take the cytological atypia, it is either absent or very minimal in amount only. So the cytological atypia may or may not be seen only. So if you take the low grade, increased cystic component is going to be there, lot of mucus cells, few amount of intermediate and epidermoid cells, and cytological atypia is nil or very minimal in amount. Moving to your intermediate grade. If you take the intermediate grade, the amount of cystic spaces will be slightly reduced when compared to the low grade. Low grade, we see lot of cystic spaces and less amount of your solid areas. Whereas your intermediate grade, the amount of cystic spaces is decreased. It's still present, but it's 50-50 is going to be there. 50-50 meaning little amount, 50% of your cystic spaces and 50% of your solid areas can be appreciated. So it will show cystic spaces as well as the solid sheets of your cells. If you take the cystic spaces, again the cystic spaces will be lined by either your mucous cells, cuboidal cells, or the columnar cells. The solid areas, if you take, it will consist of few amount of your mucous cells, more amount of your intermediate and the epidermoid cells. So the intermediate cell component will be more in case of your intermediate type of your mucoepidermoid carcinoma. That's why it's called an intermediate grade. So the intermediate cells will be more in amount, and the cytological atypia might be there to some amount in case the cells which will be involved will be your intermediate and the epidermoid cells will show the cytological atypia, not your mucous cells, only the intermediate cells and the epidermoid cells. If at all the cytological atypia are seen, will show the cytological atypia like a prominent nucleoli, few amount of your mitosis can be seen, cellular pleomorphism can be appreciated. Moving to your high grade, here the cyst formation is totally nil and zero here. You will not have any cystic spaces or cystic areas which is going to be there in your high grade. It will contain sheets and sheets of your tumor cells only. And the tumor cells here will be only your squamous cells and your epidermoid cells. Okay. So only it consists of your squamous and epidermoid cells and few amount of your clear cells here. And these squamous and intermediate cells will show the all the cytological features or the cytological atypia can be appreciated. The cellular pleomorphism can be there, anaplasia can be there, mitotic activities will be more in amount, and then prominent nucleoli can be appreciated. Along with that, there will be the surrounding stroma will show necrosis can be appreciated, focal calcifications can be seen. All these can be seen in case of your high grade tumor, and if you take the mucous cells will be decreased or nil. Okay, there will be either decrease in amount or totally nil in your high grade tumor. And if you take the high grade tumor, it is of two types is going to be there. One which will resemble like a moderately differentiated squamous cell carcinoma. So it will resemble like a moderately differentiated squamous cell carcinoma, or the second type where it is going to have a mixture of cells. It's going to be the mixed type of your high grade tumor. So moving into your the first type, that is your moderately differentiated squamous cell carcinoma. If you go back to your epithelial pathology or the moderately differentiated squamous cell carcinoma, there you will be able to appreciate minimal amount of your squamous islands can be seen, the tumor islands and the keratin pearl formation there. Same way here, you will be able to appreciate lot of your epidermoid cells. So in case of your high grade, the first type which resembles like your SCC, it will show more amount of your epidermoid cells or the squamoid cells, and these epidermoid cells or the squamoid cells will show the cytological atypia. Along with that, will show lot of mitosis, individual cell keratinization, and keratin pearl formation can be appreciated in this type of your high grade tumor. Whereas the second type, which is your mixed type variety, where you will see more amount of intermediate and the squamous cells. So combination is going to be there. It is not going to show only the intermediate or the squamous cells. It will show increased amount of your squamous cells and the intermediate cells, which will show all the features of your cytological atypia. And it will be more showing the necrosis because it's a more vigorous one. So it will show more amount of your necrosis. Anaplasia can be there, cellular pleomorphism can be there, and increased mitotic activity can be appreciated. So if you take the high grade itself, it is of two types. One which resembles like a moderately differentiated squamous cell carcinoma, and a mixed cell type which will show increased amount of sheets of your squamous and your intermediate cells. Both the variety will show lot of mitotic activity. The cellular pleomorphism and the cytological atypia can be appreciated. So these are the basic grading of your mucoepidermoid carcinoma. Moving into FNAC, you know FNAC is a fine needle aspiration trial. So before you see any tumor that is going to be a major or a minor tumor, you're going to do a fine needle aspiration cytology. So if you do a fine needle aspiration cytology, this is the picture what you're going to see. You see, you put a specific stain here for the FNAC. You take a smear, put it on a slide, and you're going to stain it. The stain what you use here is called the MGG stain. May Grunwald Giemsa stain. May Grunwald Giemsa stain or the MGG stain. The characteristic which is used for all your salivary gland tumors. So what do you see in the FNAC? In the FNAC, the characteristic finding will be the background of the smear. The background will be appearing very dirty. Okay, it will be very the discolored and dirty. Why? Because of the mucin content there, which is there in the tumor itself. So it has a dirty background, and the cells which you're going to appreciate will be more amount of your intermediate cells and few amount of your streams of your mucous cells can be appreciated. That is the characteristic FNSE finding in case of your mucoepidermoid carcinoma. The dirty background, it will be blue violet in color when you use that MGG stain, and the cells which will be seen will be your intermediate cells in sheets, and strings or streams of your mucous cells can also be appreciated. And histopathology I already told, it will have cystic spaces which will be lined by your mucous cells and your cuboidal cells. This is the histopath picture showing it. So these are the cystic spaces. These are the cystic spaces which will contain your mucous cells. These will be containing the mucin poolings here, the surrounding stroma showing the solid areas. These are the solid areas which consist of your epidermoid cells. The high grade, high power view showing your mucous cells. The foamy cytoplasm with the nucleus pushed to the periphery. These are the polygonal epidermoid cells, the extravasulated RBCs, and your cystic spaces you are able to appreciate here. And these, the small cells will be your intermediate cells. I told you basal-like type of cells which will resemble like a basal cell. These are the intermediate cells. More of a cuboidal cells with minimal cytoplasm, large hypochromatic nuclei. And this picture shows your clear cell, the clear vacuolated cytoplasm with a prominent nucleus. This is how you differentiate. In case of your clear cell, the nucleus will be in the center only. Whereas in your mucous cells, all the nucleus will be pushed to the periphery. That's how you differentiate a clear cell and your mucous cells. And your clear cells will all appear empty. It will be vacuolated or empty. And this is the polygonal cells or the epidermoid cells. This is how you differentiate this. Very minimal cytoplasm, more amount of cytoplasm with the prominent intercellular bridges. And there's another criteria which was given. The parameters will be your intracystic component, which will be less than 20%. The points given will be 2. Any neural invasion. I told, right, there's going to be necrosis. Along with necrosis in a high-grade tumor, there is going to be perineural invasion. What is perineural? You have a nerve bundle there. Surrounding that, you will be able to see the tumor cells. That is the neural invasion or the perineural invasion. Next, necrosis can be seen, which points will be given will be 3, and 4 or more mitosis in a 10 high power. 3 points are given, and anaplasia will be your 4. Then based on these parameters, it will be graded as low grade if the point score is around 0 to 4, intermediate grade if it's going to be 5 to 6, and a high grade if it's going to be 7 to 14. The next grading type will be one which shows all these parameters. That is your intracystic component, which has less than 25%. The tumor front invades in small nests and islands. So small clusters of cells or large islands. Pronounced nuclear atypia. Any lymphatic or vascular invasion. Any bony invasions or mitosis more than 4 in number. Perineural spread and necrosis. Based on that, it can be graded as 1, 2, and 3, low, intermediate, and a high grade. 1 point score, all these are going to be not there. 2, when only 2 or 3, and 4, more than 4. So these are the grading systems which has been put for different grading systems for your mucoepidermoid carcinoma. But the common is what we follow here is your this grading, where based upon the cystic formation, degree of cytological atypia, and the amount of the cells which are going to be present, it is graded as your low grade, high grade, or your intermediate grade type of your mucoepidermoid carcinoma. Next, moving on to the types of your mucoepidermoid carcinoma or the variants of your mucoepidermoid carcinoma. The initial one, what I told, was involving your salivary glands. In this itself, there is something called as sclerosing mucoepidermoid carcinoma. Sclerosing means fibrosis. The surrounding stroma will show a lot of fibrosis there. So this is one variant of your mucoepidermoid carcinoma showing lot of fibrosis surrounding the tumor islands. So these fibrosis, why this fibrosis occurs? This fibrosis, one thing they have told, could be because of the mucin secretion which is being thrown out into the extracellular matrix as a reactive phenomenon. So reaction reactive fibrosis due to any mucin deposition there. Second, what they have told could be because of any tumor infarction. These are the two things which they have told, because of which your sclerosis or the fibrosis can occur in a mucoepidermoid carcinoma. That is the sclerosing type of your mucoepidermoid carcinoma, where you will see lot of fibrosis. The current tissue surrounding stroma will be showing lot of fibrosis. Why? Because as a reactive fibrosis, because of any mucus secretions pooling there in that area, or any tumor infarction occurring in that area. Along with the fibrosis, you will be also able to appreciate few inflammatory cells also. You will be able to see lymphocytes, your plasma cells, and your eosinophils can be appreciated in your sclerosing mucoepidermoid carcinoma. Where the main type of mucoepidermoid carcinoma, the inflammatory cells will be not there at all. Whereas in your sclerosing, you will be able to, because the mucus secretions are thrown out, so which will cause a reactive phenomenon there. The reactive phenomenon, that is, you will have your inflammatory component along with a lot of your reactive fibrosis. And your sclerosing mucoepidermoid carcinoma is usually a low-grade type of your mucoepidermoid carcinoma. The second one will be your intraosseous mucoepidermoid carcinoma. Intraosseous. The mucoepidermoid carcinoma can also occur within the bone. So this is your intraosseous type of your mucoepidermoid carcinoma. And the bone involved will be either your mandible or your maxilla. If you take the mandible, it is commonly seen in the anterior region of your mandible. In case of your maxilla, it is seen in the molar ramus area. Sorry, in the molar area of your, or the posterior area of your maxilla. These are the commonest site of occurrence of your intraosseous mucoepidermoid carcinoma. And if you take this intraosseous mucoepidermoid carcinoma, it will be usually a low-grade tumor only. It will not be high-grade or intermediate type of your mucoepidermoid carcinoma. And clinically, if you see, it will be seen like a cortical expansion. A slow-growing cortical expansion can be seen. Since it's involving the maxilla and the mandible, the nerve in one cause your pain and paresthesia can be associated findings, which is going to be there. Along with that, trismus can be seen. And the radiographic finding, if you see, it will show either a unilocular or a multilocular radiolucency. Either a unilocular or a multilocular radiolucency. I told it occurs in your intraosseous or the intraosseous sites. But how come you have the salivary glands within it? So what they have told, the theory behind the occurrence of your intraosseous mucoepidermoid carcinoma can occur as a result of two things. One, ectopic salivary gland tissues which are seen within the bone. Ectopic salivary gland which is seen within the bone. The second one, we already saw the odontogenic cyst. So some of the odontogenic cysts can undergo neoplastic transformation to give rise to your mucoepidermoid carcinoma. So the 2 points which they have told, the etiology for your intraosseous carcinoma, mucoepidermoid carcinoma, is that it can arise as a result of ectopic salivary gland tissue and neoplastic transformation of the odontogenic lining epithelium of the odontogenic cyst. Okay, so we know that dentigerous cyst contains a mucus which can give rise to that. What is this ectopic salivary gland tissue? How come an ectopic salivary gland tissue comes into play here? So they have told 3 things. One, because of any developmental, during the development, entrapment of the salivary gland tissues. So developmental entrapment of the salivary gland tissues, one thing, by which your ectopic salivary gland comes into the alveolar region. The second will be any embryonal rest. Okay, during the development of the salivary gland, few embryonal nest or rest of the salivary gland tissue can get entrapped within the bone. So that is the second one. The third one, maxillary sinus. The maxillary sinus consists of your mucus glands in it. So the periosteum contains your mucus glands. So these displacement of these mucus glands from the maxillary sinus can give rise to your intraosseous mucoepidermoid carcinoma. So these are the ways in which you get your intraosseous mucoepidermoid carcinoma. One, ectopic salivary gland tissue, which can come from the developmental entrapment of the salivary gland. Second will be your embryonal rest or nests of your salivary gland tissue during the development of the submandibular or the sublingual glands. The third will be the displacement of the salivary glands which are seen in the lining of your mucus maxillary sinus. And it also can occur as a result of the neoplastic transformation of your any odontogenic cyst lining. So this is the theory behind the occurrence of your intraosseous mucoepidermoid carcinoma, and I've already told it is usually a low grade tumor, not an intermediate or a high grade tumor. So the treatment part of your mucoepidermoid carcinoma, if it's going to be a parotid gland, if it's going to be early stage, very minimal involvement is going to be there, you can go for a subtotal parotid because it's a carcinoma now. So it's going to go for a subtotal parotidectomy with the facial nerve being preserved. If it's going to be a complete or advanced stage of it or the high grade tumor, you go for a total parotidectomy. If it's going to be a minor salivary gland lesion, you go for a wide surgical excision. Okay, the surgical excision can be done with the wide margins can be given. Based upon the histological grading, if it's going to be a low grade tumor, the surrounding normal margin of the tissue has to be taken. If it's going to be, we are talking about an intraoral lesion. If it's going to be an intraoral lesion showing a low grade tumor, you're going to excise the tumor along with a little bit of the normal margin also, or the normal tissue surrounding it. If it's going to be a high grade tumor, what are you going to do? You're going to go for a wide surgical resection like any squamous cell carcinoma or any other carcinoma for that matter. And if you see the metastasis, to prevent the metastasis, you have to go for a radical neck dissection can be done. And the prognosis of the tumor depends upon the grading and the staging of your tumor. If it's going to be a minor salivary gland tumor, it's usually the prognosis because it's the small area involvement. If it's going to be the tongue and the floor, it is going to be a very aggressive tumor. The prognosis is going to be bad. So the grading, depend upon the grading. If it's a low grade, 98% of your good prognosis. If it's going to be a high grade, it's only 56% is going to be seen.